So today we'll be going over a simple primary care review in the failure to thrive in young children. Failure to thrive is defined as height and weight measurements that fall below the third or fifth percentile, or a downward change in growth across two major growth percentiles and is associated with abnormal growth and development. FTT is also associated with poor weight gain due to severe malnutrition, which can cause persistent short stature, secondary immune deficiency, and permanent damage to the brain and central nervous system. Early identification and expeditious treatment may help to prevent long-term developmental deficits. Etiology and causes. For most cases, inadequate nutrient intake is a major cause, such as not offered enough food, or is not willing to eat enough food, or vomits. Also, inadequate nutrient absorption, such as cystic fibrosis, is also another cause. Increased losses and increased nutrient requirement. The clinical evaluations. Prenatal history includes low birth weight, intrauterine growth restriction, perinatal stress, and prematurity. Past medical history. Chronic diseases of any type may affect nutritional intake, absorption, or needs. Frequent recurrent illnesses may indicate immunodeficiency, and frequent injuries may indicate inadequate supervision. Family history. Shorter parental height and higher parity may be associated with slow weight gain in infants. Review of systems. The review of systems should include symptoms of medical conditions that could contribute to poor weight gain. Diet and feeding evaluation. Detailed information of diet intake and feeding should be obtained, including the duration of meal times, the type of food, the amount of food consumed, feeding behaviors, such as particularly picky eating. Psychosocial evaluation. Psychosocial stressors are the most predominant cause of insufficient intake in children of all ages. The maternal or caregiver may not be available for the care of the child for a variety of reasons, such as poverty, parental depression, or substance abuse. Child neglect. Child neglect is responsible for poor weight gain in a minority of children. Child neglect should be considered in children if there is any history of intentional withholding of food from the child, or the family is resistant to recommended interventions despite a multidisciplinary team approach. If there is evidence of associated physical or emotional abuse, a report should be made to Child Protective Services. Physical examinations. The measurement of growth. Accurate measurement of the child's weight, recumbent length, and head circumference is essential. These measures, along with the child's weight for length, should be plotted on a standardized growth chart. Laboratory tests. Initial tests. You would complete a blood count as a screen for anemia and malignancy, C-reactive protein as a screen for chronic infection, erythrocyte sedimentation rate as a screen for inflammation, and urinalysis and culture as a screen for protein or glucosuria and renal disease. Additional tests include a CMP test as a screen for kidney, liver, or pancreatic disease. These tests also provide an indication of nutritional status. Stool studies include routine culture, ova and parasite smears, and or Giardia antigen to evaluate gastrointestinal infection. Chest radiograph to evaluate cardiac pulmonary disease. Mild malnutrition management. Increased oral intake. Infants younger than 4 months require 8 to 12 feedings per day. Infants older than 4 months require 4 to 6 feedings per day. Changes to the feeding environment. Infants should be positioned with their head up and the child is comfortable. Older infants and toddlers should sit upright in a high chair or on a booster seat at the table. Mealtime distractions should be minimized. Home based support. A visiting nurse or other appropriately trained home visitor. Referral to community, state, or federal assistance programs, such as supplemental nutrition for women, infants, and children in the United States. Follow up. Children with mild malnutrition should have regular follow up visits to reinforce the feeding plan and monitor weight gain. Moderate malnutrition management. The interdisciplinary team may be part of a specialized program. A dietitian can help in formulating the nutrition plan and strategies to increase intake. The target energy and protein intake should be achieved over 7 to 10 days to avoid complications associated with rapid refeeding. Interventions of developmental and behavioral issues and provide psychosocial support should also be provided. Children with moderate malnutrition should have regular follow-up visits to reinforce the feeding plan and monitor weight gain. Severe malnutrition management. For children with severe malnutrition or a body mass index of less than 12, hospitalization is suggested. For children with severe malnutrition, the target energy and protein intake should be achieved over 7 to 10 days, with feedings every 2 to 4 hours. Thank you.